Hi, everyone. We're going to get started here in just a minute. I know that it looks like folks are still signing on. And while you're signing on, if you could go ahead and chat in the name and the credentials of the folks who are in the room with you, whether they're an MA or an RN, we'd really appreciate that. So, and we will get started in just a minute here.
Sound effects.
Yeah, that was, huh? I know I told my husband to put the dog in the room with him, and he still has her outside. So hopefully she doesn't come in and give her own sound effects. All right, folks are still logging on. And while you're logging on, please put in the chat feature the names and the credentials of the folks who are in the room with you. We just want to know how many people each of our training sessions reaches. So, but it's 12 o'clock, so we'll get started. I'm Rebecca Nevedale.
Hi, I'm Macrina Leach.
And we are with Chappie. This is our fourth virtual tip session, and we're really excited to be providing these all summer. And thanks to the Arizona Telemedicine Program and the Southwest Telehealth Resource Center funded by HRSA. Without them, we wouldn't be able to provide these training sessions to you virtually throughout the summer. So, and we also want to thank all of you. We've been really excited about all of the feedback that you've given in the chat box. You're all like rock stars at chatting in your questions and your comments, and also by taking our evaluations. And we do use the content that you put on the evaluations to make these sessions even better. And because of that, we like to give you prizes. So I'm going to spin our wheel here. So our first prize goes to Sharon White. So thank you for filling out your evaluation. And our second goes to Norma Romero. So thank you both for filling out those evaluations. We really do use them, and you'll see that today. And we have our TAPI Executive Director, Debbie McCune-Davis, on the line today. Debbie, do you want to give us a welcome and a thanks?
I do, Rebecca, and thank you. And thanks to all of you who put so much time into planning today's session. We're talking about two really important topics today: vaccine administration and empowering parents. Have you heard the statement, vaccines are the victims of their own success? They are so effective that we rarely see the diseases that they prevent: measles, mumps, chickenpox, whooping cough. That creates a real challenge because the current generation of parents doesn't see these diseases and they don't feel threatened by them. And they mistakenly think the vaccines are optional, but we all know they're not. If we stop immunizing our children, those diseases will return. And in addition to the challenges we face every day, we will be dealing with diseases that could be prevented. As a mom, I took my kids to the pediatrician, both to keep them well by getting them vaccinated, and when they were sick, because I knew that's where I would get the best answers to getting them healthy again. And I trusted my pediatrician to give me the best advice possible. And it's that trust relationship that comes into play when we talk to parents. So what we're going to share with you today are the strategies that we've learned over time to use that trust relationship to answer parents' questions compassionately and to vaccinate confidently. And that's our strategy. That's why we've invited you all here. And that's why we work so hard to put good strategies and good information in place so every Arizona kid can have a healthy lifestyle or healthy lifetime. So thank you so much for joining us. You are what makes this work, and we're grateful you're with us. Thanks.
Thanks, Debbie. And we are also appreciative of you. So I also want to welcome Peggy Stemler. Peggy's my boss, and she's consulting with Maricopa County on COVID-19. So Peggy, spend a couple minutes, tell us what's going on with COVID-19 since last time we met. And if you have specific questions for COVID-19, go ahead and chat those in. Peggy will answer them right now. She's not able to stay on for the 15 minutes afterwards, so go ahead and chat in your questions now.
Okay. So let me go over to my screen here. And these maps of the United States just sort of give a good idea of how COVID is sort of spreading or kind of working across the country. And I left in the map on the upper left-hand corner. This map was from last time we were together. The date on the map was from July the 7th. And you can see even in the past 2 weeks, the dark red are kind of the hot spots. So these maps are showing confirmed COVID cases. So that's test positive, sometimes probable cases, which have a really strict definition for how you actually get into that category. And states report a little bit different, but very consistently over time is how they're reporting. You can see the dark red areas on the map, which were kind of dark red along the eastern seaboard and the southeastern part of the country and in Arizona. They're starting to spread throughout a little bit more of the Midwest. The country's getting a little darker overall. So COVID is definitely kind of moving along in the country. In Arizona, same thing is happening. We are now at 150,609 cases overall, and Arizona does report both the confirmed and the probable cases, so that you can see that. The other thing that's happened in Arizona is that we've had almost 1,000 new deaths since we last met 2 weeks ago. So we're up to almost 3,000 deaths in Arizona. Now, we talked about it last time and I'll reinforce it again. Yeah, testing is up, so we will be identifying more test positive cases, but with that, the rates of positive tests are also going up. So this map is showing you the map on the left that says case counts is that total number of individual people, not individual tests, but individual people who have confirmed by a test or probable by that definition COVID in the state. And on the right, those numbers are adjusted for populations in the different counties. So that you see on the right that Maricopa County, while it definitely has the largest number of confirmed cases, we also have the largest number of people in the state. Both the northeast and southwest and Santa Cruz County down at the on the south side are really the places that are the hottest spots in the state for the rates of the tests that have come up. But I think the good news is, if there is any good news, is that this is a slide from the Department of Health Services website that shows the tests overall. And if you go onto their website, you can click on the map on any of the counties and get county specific information. But this is for the state overall. But on this kind of the lower set of rectangles, but the upper line on that, this line here shows the gray bars show the number of tests that have been sent in by week since mid-February. And the red dots on those bars are the percent of tests that are coming back positive. So you see that the gray bars have been increasing over time, but you also see, so there's definitely more tests, we all know that, but we also see that those red dots, the percent of tests that are coming back positive have also increased. So that's really the marker that says, yeah, it's not just testing alone that's giving us, this increased number of cases that are going on. So the one thing I want to point out is 4 weeks ago, and I don't know if you can see my arrow, but we were at a 21% positive rate across the state for tests. 3 weeks ago, it dropped a little bit back down to 19%, and that was the first dip in a while. Now, these last two bars, you can't definitely depend on those numbers yet, because you all have been reading in the news, hearing in the news that the results are taking some time to come in, and part of that is just due to so many more tests are being done that it takes the labs a while to process them. But last week, and the data is still incomplete, but that's only right now at 16% positive. So very, very cautiously, this is an optimistic sign that the policy measures and also the behaviors that we've all been doing, once that curve kicked up high, we had hot and heavy spread in Arizona, but as people have, I think, started to both be kind of more cautious, masking up, staying probably a little bit more distant, that those measures have started to bring the curve back down, and that's really good news. So I'm going to stop the slides there and try to look at the chat. And, if you guys also want to help me with that, that would be great.
And Peggy, you can answer, if you can stay on for just a little and answer the chats in the chat box. But Jennifer had one question about where can they get more information about disease physiology and how the disease progresses in patients?
So that's a great question. The CDC is probably a good place just to look, because they tend to compile the information that, sorry, Dusty is coughing in the background here, dogs, that compile the information that has come through kind of the strong research. But I think the biggest caveat to that is that this is still pretty new, so things evolve all the time, so that the early kind of understanding of what the disease looked like has been changing over time. And I think the biggest take home for that right now is that COVID can look very, very different in different people. So right now, the estimates are like 40% of people have asymptomatic, are positive, but are asymptomatic, and that's not pre-symptomatic, which means you're going to get symptoms sooner or later. They just don't have them. Some people have just sort of the sniffles or a little bit of, aches and pains and some belly stuff going on. Other people can get seriously ill, and there's a whole range of things in between that can happen. So I think the biggest message is that you can check on the CDC for that kind of clinical constellation of symptoms. But right now, COVID can kind of look like a lot of things. And so in your own work, when you're out with friends, unless it's something like somebody has had seasonal allergies year after year after year and nothing is different, or other sort of similar, a chronic cough due to something, any symptoms, people need to stay home, quarantine yourself until you're sure what's sorting out.
Thanks.
All right.
So, and Peggy will go ahead and look through the chat and answer the other questions too. And we'll be able to copy and paste those questions and answers so that everybody can see them. But we did want to launch a poll. Oops, sorry about that. Peggy, I was supposed to share your slides. So now you've messed me up and made me look bad in front of my boss. So, and Chris, could you launch the COVID poll? We're curious, if you think about the last month, so the last 4 to 6 weeks, how has COVID-19, the pandemic, impacted your immunization coverage rates? So do you think that in the last month, your coverage rates for vaccines have decreased? Have they stayed about the same, or have they increased? So we'll give you a minute to answer that. And this question probably looks familiar because we asked it in the very first training session, and we were just interested to see, since we've been meeting with you all, we feel like the world has just changed so much since we started. So we're curious if your answers look the same or different to this question. So whenever it looks like folks are slowing down their answering, Chris, if you could show us those results. And we know, you have really gotten, life has changed for all of us, but those of you who work in clinics have really gotten the brunt of having to change your complete workflows. And we're just so appreciated. And it looks like that things maybe have gotten a little better in the last month. So when we first asked this question, 56% of you thought coverage rates had decreased, and now only 47% of you say that they've decreased, which is good. More of you think that they've stayed about the same, but less of you, and let's see, and more of you think that they've increased. So that's great. We thought you'd be interested in seeing how that changed too. Okay, so today we are talking about vaccine administration and educating patients, and we did take a hard look at our evaluations. And one of the things that we noticed was that we may need to hit a little bit harder some of the things around vaccine preparation. And that's based on some feedback that you all had about making sure that your colleagues, especially those new to immunizations, which we know almost half of you probably are, may have missed some important information. So I'm just going to breeze really, really fast through a recap of vaccine preparation and what we talked about. So 2 weeks ago when we met, we talked about ordering vaccines, appropriate ways to handle and store. We talked about appropriate temperatures, and this was one area where the evaluation said, hey, scream at all the new people. Temperatures are really important. So we want to make sure that they're really important. And if vaccine goes out of range, a couple things can happen. First is, if you administer a vaccine that was at a temperature range, it's ineffective. So you have to call that patient back in. And you don't want to have to do that. And the other thing is that someone at your practice actually purchased that vaccine and it cost money. So it's kind of like throwing money away if you let those vaccines go out of range. And if that dose was a VFC dose, remember, you're going to have to replace that dose that was wasted because it went out of range with something that you purchased. So that's really important, not just in transporting vaccine in the event of emergencies, but just as it sits in your fridge. So we also talked 2 weeks ago about checking immunization status of your patients throughout the scheduling process during pre-visit planning so that you know what they're due for. We talked about screening for contraindications and precautions. And all of those things happen before you say, present vaccination as that default option and say, today you are due for these shots. And when you say that, most of the time your patients say, great, can't wait. Or at least, I know we're getting them. So it's really important once you get that yes, from your patient, you're going to want to provide them with the VIS form or offer it to them. You're going to get the consent from the patient about the vaccines that you'll be providing, and then somehow communicate with the provider that that patient is now ready to go. So you do that through your EMR or verbally, or you flip the flag up in the exam room door, however your practice does that. And we know that some practices actually get the consent from the patient after the provider visits and talks with the patient or the family. Just know how your practice does it, what's your process, and do it that way. But does anyone have any questions about consent or VIS forms? Macrina, for VFC, do they have to provide that form?
So you have to the only rule is you have to make the VIS available, and that's whether it's VFC or private purchase. So you have to make it available for the parent to read it and ask any questions. If they want to take it with them, a copy, you can do that. We have a lot of parents who say, I've read this 4 or 5 times, I'm good. But you do have to just make it available.
Okay. So now the provider is in the exam room with the patient. Have many of you have standing orders, and this is a CDC best orders are. So we will. I'm getting a little bit of background, Chris. Is it me? Oh, I think it's Debbie, Chris. No. Let me chat in. Okay, so can people hear me a little better now? I see in the chat folks weren't able to hear me. Yes. Okay. Thanks, Angie. Thanks, Charlene. Okay. So CDC does recommend standing orders as a best practice. We will send you some templates for that. And we ask that you do forward them to your practice managers or the physicians in your practice, because we know that standing orders do help improve coverage rates. But there are other reasons why your docs in your office and your management may choose to not use them. So if that's your practice, then you propose the order. However you do that, you get the vaccine, you check and make sure it's not expired, it's the right dosage, it's the right vaccine, you double check it. A lot of your practices have policies that another MA double checks that. That's a great procedure to have. You wash your hands, you prep the vaccine, you label it. You want to make sure you label it, because parents change their mind sometimes halfway through. So they'll say yes to the first 2 shots and then the next shot, the last one not. And you want to know which one you didn't give. Same if the 4-year-old ninja kicks it out of your hand, you want to know which one was kicked out of your hand. So labeling is really important. And then you head right back into the exam room and you administer the vaccine. So Macrina, talk to us about Macrina's favorite people to immunize are babies. She thinks they're the easiest.
Oh, I think babies are so much easier. And this is truly a skill. I mean, I have been giving immunizations for a long time. Y'all out there who are immunizing babies, toddlers, school-age kids, adolescents, teenagers, adults, this is a skill set that not everyone has, and a skill set that takes some time to practice. So thank you to everyone, because this is not an easy job. First thing we talk about is comfort holds. Let the parent hold. And you just got to really give clear instructions to the parent. Please give a really tight hug. I'll let you know when I'm done and you can let go. But if you just give the parent really clear directions, to hold the baby. The other is that if a mom wants to breastfeed while immunizing, go for it. There's actually some data and studies out there that show that it decreases pain, and it actually increases comfort of the infant. So definitely let the mom breastfeed if she wants to. And this is how you hold babies. And then the next slide. This is older kids. This is actually my favorite picture of the dad who's whispering in his ear and giving the little boy a kiss. Just let parents know that what they're doing is the right thing. They're doing it to protect their children and keep them healthy. I know it's scary that you don't ever want to do anything that makes your kiddo cry or scream, but that you really are doing the right thing, and that crying is normal. It's scary. So just support the parents in giving that really tight hold. Okay, so there's 2 forms of administration that you have to use a needle for. The first one is subcutaneous. If you have to give 2 sub-Qs in the same arm, you're going to separate them by 1 to 2 inches. And if you look, really all you need is some fatty tissue. So with adults, it's like right behind the arm there. Unfortunately, I got a good amount to grab onto. You can actually find that in babies. You can also find it in the leg as well. A little bit of fatty tissue for a sub-Q. And then the next we're going to talk about is IMs. You're going to want to administer into the muscle. You're going to go at a 90-degree angle. There's no need to aspirate anymore. It took some of us seasoned, older nurses some time to break that habit. If you give 2 IMs in the same site, they need to be separated by 1 to 2 inches. The other with the IM is that you want to make sure you use an adequate length of needle. 1 inch or 1.5 inches, depending, but you need to be able to get through that fatty subcutaneous tissue and get that vaccine into the muscle, because that's where the vaccine is going to work its best. That's where it's been studied to work and build a response, and that's where it's the safest.
Yeah, we hear a lot, Macrina, that people are scared of the size of the needles.
Yes, it's amazing how long an inch looks when it's a needle as opposed to when it's anything else. But again, I just explained to both parents of infants, because we use a 1 inch needle, as well as parents of 4 and 5-year-olds, as well as adolescents and teenagers, is that you really need to get that vaccine into the muscle. It's going to hurt a lot more if you don't get it where it needs to go. So 1 inch or 1.5 inches, you're doing the right thing. Don't be fearful of the needle. Okay, with infants and toddlers, 3 years and under, 36 months and younger, you want to go into the vastus lateralis. You want to go into that big muscle right there on the thigh. And when you hold that baby's leg and bend the knee, you can definitely see it. You want to try to get right there in the middle. And then you can give 2 IMs. You just separate them by 1 inch to 1.5 inches. And with older children, 36 months and older, and adults, you're going to give it in the deltoid, and you're going to want to make sure that you get it right. You're going to visualize the deltoid, and you're going to give it right there in the middle. You want to make sure you don't get it too high. If you get it too high, you're going to get it in that joint, and that's going to be really painful. You're going to give it right there in the middle of that deltoid. So there are vaccines that are subcutaneous, and there are vaccines that are intermuscular. You've got to give them the way that they are instructed to be given. That's how they work. That's how they've been studied to build an antibody response. Your subcutaneous MMR, varicella, and polio. When giving polio alone, it is sub-Q, but it can also be given IM. So as you know, some of those combination vaccines that we use in the kiddos has polio, and that's given IM, and that's perfectly fine. IM is all of your diphtheria, tetanus, pertussis, Hep A's, B's, Hibs. You can read all of those on there. And for all of you who do adults, just remember that the Shingrix vaccine, which is the newer zoster vaccine on the market, is given IM. The one that we were giving previously was sub-Q. Now, here's what Maricopa County uses. It's not required, but we just use it as another form of a way to keep us a little bit better organized. Is we have vaccines that go on the right, we have vaccines that go on the left. That way, routinely, if somebody calls and says, you know, my left arm is really sore, we know that they received the tetanus-containing vaccine. It's just a way for us to be a little bit more organized. You're more than happy to use these, but you don't have to.
And this reminds me too that you have a good bubble there about don't attempt to immunize an uncontrolled child. If you can't, if the parent does not look comfortable holding that child, or just isn't doing a really good job, go get a buddy or 2 or 3. And you've all had patients where you need quite a few buddies.
Right.
Just so that patient is safe and so that you're safe too. So.
Yeah, the whole goal is to make sure that everyone is safe and that no one gets injured. If moms or dads are having a lot of trouble, a lot of times parents are the ones with the fear of injections and needles. So if they seem that they're having some trouble holding, then I usually just ask, is it okay if I get one of my coworkers to help? They can help you hold. And a lot of times all you got to do is ask, and sometimes you'll just say, well, what if I help and give everyone a hug, mom and kiddo? So there's ways to kind of help the parent who's a little bit nervous.
And Amanda's asking, where can I get this handout? And we'll send this out after the session too.
Yep, then we have oral administration, which is our rotavirus vaccine. Always give the rotavirus first. It's always a little bit harder to get it for a kiddo to take it once they're not real happy with you. You're going to give it between the cheek and the gum. And don't worry if this, yeah, I know, it's like that old commercial. Make sure that if they spit up a little bit, you're perfectly okay. they dose it so that we know the babies are going to spit a bit up. The only thing I would do as to this picture is I would have a little Kleenex, because that rotavirus is a little sticky and you don't want to send a poor kiddo out with sticky lips and chin. Okay, next one. And then the intranasal, the live attenuated flu vaccine, the flu mist. This is really important, and probably the vaccine that we see administered incorrectly a lot. You want the kiddo to be sitting straight up. You don't want their head laying back. You don't want it laying forward, just straight up. Don't go too far up. Don't go too far up the nostril, because you don't want to get it too far back there, because you'll kill the vaccine. But as you can see, you're just going to stick it in the tip of the nose. You're going to give one side, then you're going to give the other. No need for them to take a deep breath or anything. Okay, and now we have a video, and this actually is immunizing adults. And we're going to show this video is both a pre-filled syringe and a vial.
And I'm just making sure that I put the sound on there. I did. And this was made for EMS providers, right? So this won't look like your offices, isn't that right?
Right, this isn't gonna look like your offices. This was put together to give a short updated training to our paramedics who are out there providing vaccines.
Hi, I'm Kristen Park, Public Health Nurse with the Maricopa County Department of Public Health, and today we'll be doing a quick overview on how to give an IM injection. First, we'll review the process using a pre-filled syringe and a safety-like needle, and end with reviewing the same process using a Vantage Point retractable syringe. Let's begin. Hi Jenny, how are you? First, identify your patient and explain what vaccine will be given and which type of injection will be done. If it's within your scope of work, screen for contraindications and verify that your patient has received a vaccine information statement and has had time to review it and ask questions. Perform proper hand hygiene prior to preparing the vaccine. Gather the appropriate supplies, including the correct needle length and gauge, sterile alcohol, and bandage. Verify that you are removing the correct vaccine from the box and check the expiration on the syringe. Pick up the pre-filled syringe and make sure there is no discoloration or precipitate. Next, remove the needle from its packaging. Be careful not to touch the hub of the needle. Hold the needle by its protective cap and attach it by twisting it onto the tip of the syringe. Remove the small amount of air in the syringe and recheck the expiration date and vaccine. For an IM injection, the deltoid muscle is the preferred site for adults. Identify your injection site by having the patient relax their arm. To locate the landmark for the deltoid muscle, expose the upper arm and find the acromion process by palpating the bony prominence. The injection site is above the level of the armpit and approximately 1 to 2 inches below the acromion process. Now, clean the area with alcohol and allow the site to completely dry. Control the limb with the non-dominant hand. With the dominant hand, inject the needle quickly into the muscle at a 90-degree angle. Inject the vaccine using steady pressure and withdraw the needle at the angle of insertion. Make sure to activate the safety shield immediately after removing it from the patient. It's important to activate the safety shield away from self and others. Finally, after properly disposing the needle and syringe in the sharps container, you can apply a bandage, perform hand hygiene, and remember to document injection site and procedure per policy. Now that you've seen how to give an IM injection using a pre-filled syringe, let's see how this process looks using a Vantage Point syringe with a single-dose vial. First, identify your patient and explain what vaccine will be given and which type of injection will be done. So today you're getting a Tdap.
If it's within your scope of work, screen for contraindications and verify that your patient has received a vaccine information statement and has had time to review it and ask questions.
Nope, not at all.
Perform proper hand hygiene prior to preparing the vaccine. Gather the appropriate supplies, including the correct needle length and gauge, syringe, sterile alcohol, and bandage. Verify that you are removing the correct vaccine from the box and check the expiration on the vial. Next, check to make sure there is no discoloration or particulate matter. Remove the protective cap and clean the stopper with a sterile alcohol wipe. Carefully open the needle and syringe and remove the cover from the needle. Hold the vaccine vial with your non-dominant hand and insert the needle straight into the center of the stopper. Pick up the vial and syringe together and invert them.
Hold the vial and syringe at eye level and carefully pull the needle down so the tip of the needle is in the liquid. Withdraw the vaccine by pulling on the plunger and removing all contents of the single-dose vial. Carefully recap the unused needle and tap gently on the syringe to release any air bubbles. For an IM injection, the deltoid muscle is the preferred site for adults. Identify your injection site by having the patient relax their arm. To locate the landmark for the deltoid muscle, expose the upper arm and find the acromion process by palpating the bony prominence. The injection site is above the level of the armpit and approximately 1 to 2 inches below the acromion process. Now, clean the area with alcohol and allow the site to completely dry. Control the limb with a non-dominant hand. With a dominant hand, inject the needle quickly into the muscle at a 90-degree angle. Inject the vaccine using steady pressure and fully depress the plunger to activate needle retraction while the needle is still in the patient. Finally, after properly disposing the needle and syringe in the sharps container, apply a bandage, perform hand hygiene, and document injection site and procedure per policy.
Thank you.
All right. So I think our friends who work only in pediatrics are probably thinking, boy, that looks a lot easier, but trust me, it's not. And I think those of you who immunize only adults would say sometimes those 6'5" tattooed guys from head to tail or head to toes go down because they freak themselves out so much. And sometimes that people don't just sit there like very calmly, lots of different reactions. So talk to us about what's typical reactions though, Macrina. I'm sure the 6'5" tattooed guys do go down though. And you're muted. Oh.
There we go. Okay. Those tattooed guys go down. Also, sometimes they just don't sit still enough. If they won't sit still, then they got to go. Poor Kristen Park, who did this video, had to ask a very nice gentleman to leave because he couldn't sit still. So sometimes adults are a little bit harder. Okay, so managing reactions. These are side effects. You get side effects with everything. Some antibiotics cause diarrhea and abdominal discomfort. You don't stop taking them because you want to take the full course, because you want to beat whatever you're brewing. And so there are normal side effects to vaccines. And I think the best thing to do is just to make sure that you let parents know what to expect. Localized reactions, soreness, a little redness, maybe some itching or swelling at the injection site. It's usually very small and mild. You might see a little bit of bleeding or bruising. Sometimes we see a little bit more bleeding in the warmer months, or when we have those babies come in that are wrapped in 7 layers of blankets. Or you have the kiddo who's a little bit more of a fighter and a kicker and isn't being able to be held really still. Sometimes you'll see a little bit more bleeding and a little bruising. Best thing to do is always just let parents know what happened and that it's going to go away and what they can do to actually make it feel better. Make sure though that you tell them to really move their arms. We had a kiddo whose parent allowed them to put their arm in a sling for 24 hours. And that could be a little painful. If you got to move it, you got to get that medicine out of that muscle. Then there's psychological, that fright and syncope that we see, and you see it coming. Paleness, sweating, nausea, dizziness, that's even sometimes before they actually sit in the chair to get the immunization. You can I'm sure you all can recognize that adolescent that's going to pass out a long time before you actually give them an immunization. A lot of times they fall without loss of consciousness. Sometimes they have a few seconds loss of consciousness. This is why we routinely ask all of our adolescents, especially when was the last meal you had, when was the last time you ate or drank anything, because when they get really scared and worked up and it's on either they're dehydrated or it's on an empty stomach, their blood sugar's a little low, they're more likely to pass out. And then you have systemic, you have some fever, malaise, muscle pain, some headache, maybe a little loss of appetite. And again, that's just that vaccine building a response. The term in our house when I was growing up was feeling punk. You would always feel punk. It meant you weren't sick enough not to go to school or do what you needed to do, but yet you weren't feeling 100%. So I always kind of use that term to parents is that kids may feel a little punk. Not 100%, but they're definitely not sick. It's just that vaccine working within 24 to 48 hours. It's all going to be gone and everything will be back to normal.
Macrina, Lynn's in the chat is saying that people have rarely reported a lump or hardness at the site over several weeks. Baby shot in the vastus, is this normal?
It's not routinely normal, but sometimes we will see sometimes a hard site. We will recommend a lot to babies and moms, maybe use a little bit of massage around that site. You don't see it a lot, it's very rare, but usually if it does happen, it'll just absorb and go away in time.
And then Janine's saying we give 9 vaccines at once to refugees. They will often become pale and faint. Should we fill out a VAERS form for these types of reactions?
We do not fill out a VAERS form for those type of reactions. Yeah.
Yeah, so let's talk about VAERS.
So that's a vaccine event reporting system, and it monitors vaccine safety, along with, there's many other sites that also monitor vaccine safety, but this is the one where anybody can report. The provider can report, the parent can report. I once had an 11-year-old kiddo who felt like he lost his ability to dunk a basketball because of the vaccine, and he demanded to report, so they can report, anybody can report. Anything, we usually recommend reporting any vaccine reaction that the parent routinely can't handle alone at home. If there's something like this sore arm that requires medical follow-up, then you definitely want to report those. Anything with a high fever that takes several days, even if the parent can treat it at home, we recommend you report. If in doubt, report the reaction. That's perfectly okay. The folks at VAERS will actually go through the reports, and if they feel like it needs to be followed up on, then they will get back with you and follow up and ask for more information.
Yeah, Chris, we'd love it if you could launch the poll, adverse, I think it's called. We're curious if you've ever really seen an adverse reaction. So remember, there are typical reactions that we would expect to see in patients. And then a true adverse reaction is something that a family wouldn't be able to take care of at home, that would require medical attention, right?
Right.
And we know that the national statistics are about 1 in a million that we get an adverse reaction. So the likelihood is really rare. So we just thought it would be fun to ask you all. So go ahead and fill out that poll. And after you administer the vaccine, we need appropriate documentation. Your EMR or some sort of log has everything, I'm sure, already that's required, the things that are right here on this slide. And then there's other things that are best practices. But Macrina, oh, it looks like some people are, quite a lot say that they have seen an adverse reaction. I'd love it. Maybe if you chat those in, it might be interesting to see what wonder if we're defining how we're defining adverse reactions. So go ahead and chat in what you've seen as an adverse.
And again, I always recommend that when a parent follows up with you and you try to explain and give the education, and that just this is a typical normal side effect to getting the vaccines. If parents do request and demand that you report it, then a lot of times I'll go ahead and say, you know, it's not truly one. But again, there's no harm in reporting something if you're unsure. They will weed through all of those.
Yeah. Yeah, and you can look up.
Yeah, I just saw that. Do you all know that a rash 7 to 14 days after receiving an MMR is a perfectly normal reaction? You can actually see that occur. It occurs in a good portion of the population. It looks more like a heat rash, and it usually goes away in 12, 24 hours. Children aren't contagious. They don't have measles. It's just the vaccine building an immune response.
So that's not an adverse reaction.
No, it's a perfectly normal reaction.
Macrina felt pretty punk after she got her Shingrix, but that was a typical reaction, and she only felt punk enough to not have pizza and margaritas for one night.
No, actually, I did have pizza and margaritas that night. I just didn't clean the closet.
Yeah. Maybe during our Q&A, we'll go back and look through some of these things that folks are putting in just to make sure that we share it. Can you tell us what we have to document if the patient refuses?
So if a patient refuses a vaccine, and these are also patients that come in with an alternate immunization schedule, one that they have written up on their own, you're going to document any time where a patient is recommended to get a vaccine at a certain age and spacing. If a parent refuses or doesn't want to get that vaccine or get it at a later date, you need to document that. You need to document that they choose to refuse. You should have a refusal form that says I've been educated, given the information. I choose not to have my child receive this vaccine. This is really to put in place to protect both yourself and your provider and your office or your health systems. Because like I always tell parents, I'd rather you get the MMR today and not come back in 2 weeks. But if by chance they refuse that vaccine and go out and get exposed, then we need to document that it was a parent's choice, not our fault for missing it.
Right. All right.
To tell your provider.
And I know that there's a lot of good, just to say again out loud, I'm glad that people are chatting in what those adverse things that you've seen, but some of those are typical reactions, not adverse reactions. Adverse reactions happen. And I think it's important that we communicate that to patients when they ask. So when a patient says, can something bad or dangerous happen? Well, yes, like that 1 in a million times that does happen. But we're seeing a lot of people, like fainting is not an adverse reaction. Sore arms for extended period of times would be typical reactions. So we want to make sure that we're honest with families and with patients. We don't want to say something, we don't want to provide inaccurate information, but it's important to be clear too in the language that we use, that those are typical reactions. It's not an adverse reaction. So, families, we're going to spend the rest of the time talking about how do you educate families. And at the last session, you all took a poll and made lots of great comments in the chat box and on the evaluations. And we're going to spend most of our time going through really specific questions, the top ones that bubble to the top as the questions that you get from patients all the time that you'd love ideas on how to help answer those questions. But we want to make sure that we say really loud and clear, questions do not mean someone is anti-vaccine. Questions don't mean even that someone is hesitant. They're just questions. These are really big decisions about how to take care of our own personal health, how to take care of our children, and how to take care of a new little baby that a new parent is just trying not to break. So, it's really important that you answer those questions, but don't look at everything as hesitancy or someone trying to be difficult. They're just trying to get information from you.
Right. And just remember that unlike, Debbie, when she talked about taking her kids to the pediatrician, because that was the person who had all the answers and she knew she could trust them. You got to remember today parents are getting advice and information from so many more sources that it can get sometimes too much information is confusing.
Yeah, absolutely. So we'd love to hear your ideas on how have you answered this question. If you want to chat this into the chat box, we'll go ahead and kind of assemble all of those as a resource for you all to share afterwards. But this was, over half of you said this was the question that you most wanted ideas about how to answer. Why should I get the flu shot? I never get the flu shot. I never get the flu anyway. So how do you answer that, Macrina?
Well, I think you really need to kind of gauge the client or the person you're looking at. But, there are some who I know, I get the sense that I could say, well, have you ever been thrown from a vehicle before? Because I'm sure you wear a seatbelt. And then they kind of laugh, or sometimes that's, you can kind of be called a smart aleck, so that may not be the way you want to go. But the reason why we give flu vaccines is so you don't get the flu. And just because you never got the flu doesn't mean you're never going to get the flu. So I think sometimes I just sort of ask them, I'm a little confused. Just because you haven't gotten the flu doesn't mean you can't get the flu. So why don't we get the flu shot to make sure you continue not to get the flu? Because I find that to be the most confusing statement ever.
Yeah, and if you have other ways that you answer that question, we'd love to see them in the chat too. Jennifer Miller saying that talks about you are benefiting from other people's immunization.
Oh, that's a good one.
Yes, it is. The flu shot, remembering back to that very first session we talked about herd immunity and that all vaccines protect lots of other people. All right, and we're getting some other questions of how do I answer this question in the chat box. Do vaccines cause autism? We still hear this, right? So chat in what your ideas are for how you answer that question. And Macrina, tell us, what do you do when people talk about this?
Well, I just go right to the fact that they have been doing studies now for almost 20 years. And that there has not been a single study that documents and proves that vaccines cause autism. And then I talk about Autism Speaks, which is one of the largest support groups and research groups for autism. And they say vaccines do not cause autism and recommend that all their families get immunized. And that physicians who diagnose and treat children with autism want this to go away, because the sooner we stop studying do vaccines cause autism, we can get to actually start studying what may cause autism.
Great. Aubrey's saying that she tells patients the doctor who published that first study was debunked and the study was debunked and lost his license. So I think that study is still on, unfortunately, lots of social media feeds and things like that. So that's good. Jennifer says, I see vaccines are proven safe and offer to provide evidence-based information. So that's great. And I like this tip from Lisa Winter. And I think this is talking a little bit more about the flu shot question to adults than a parent who's concerned about autism. I typically try to bring humor to the patient, such as, well, why drive a car if you can get in an accident? Or why walk across the street if you can get hit by a car? Usually, this helps to lighten the situation, and then I can better educate that they are being protected by other people. So that's a
good one.
Yeah. Also, using this question as an opportunity to also educate about developmental milestones, that these are things that are typical developmental milestones for your child. So our third one, which there's lots of people talking about this, but is it safe? And we have a couple, this question can look a variety of different ways. I worry that these new vaccines aren't tested. Do you know what they put in those things? How do you talk about safety, Macrina?
Well, I do talk about the fact that many vaccines have been tested for many years, and there have been millions of doses of vaccine administered worldwide. Even a new vaccine, which I think is odd that they still call HPV a new vaccine and it's been out forever, is that they track the safety data and that millions of folks have been immunized. Second of all, is that a lot of things that they put in vaccines are in the air, they're in the foods we eat. And so, and that actually they're put in the vaccines to make sure the vaccines remain safe.
Yeah, Aubrey's commenting on here that most parents see ingredients list on the VIS and almost immediately second guess their decision. How do we reassure them this is what's best for their kids?
I think a lot of the ingredients are put in the vaccines to make sure the vaccines remain safe and work. And they've been studied over and over and over again. And then I just start talking about, that there are all sorts of ingredients in other products that we use. Toothpaste, formula, and that, again, I just try to say that so many of this stuff is in the air we breathe, in the foods we eat, in the water we drink, in the fish we eat. And that there are some minuscule small amounts and they are safe.
Right. And if they're really great.
I come back to me a lot too. I say, I have been a kid nurse for 32 years. That's been my entire career, is being a nurse for kids. And the last thing I want to do is I want to make sure that we have healthy kids, and I want to make sure they're safe. And usually when I kind of back into that, they sort of get, you know, it's a little bit of that I care too.
Mhm. Aubrey likes to say there's more mercury in a can of tuna than in a vaccine when people talk about ingredients. So,
Yep.
you know, Children's Hospital of Philadelphia, the Vaccine Education Center there at CHOP, and we'll send you this link afterwards, has some of the most comprehensive list of every question you have ever heard from a parent, they have an answer to. And the resources they have on ingredients and telling you what those ingredients are for is super, you know, why aluminum, trace amounts of aluminum are in vaccines are really good. So we'll make sure we send that out. The next question that folks said they really wanted help and ideas about how to answer are just about the schedule. So too much too soon, why can't I just get 2 shots at this visit? What do you say for that?
So I say that I usually go back to my, that I am 56 years old and I've been getting diphtheria, tetanus, and pertussis at 2, 4, 6, and 12 to 15 months because I found my immunization record. So that vaccine's been studied for a long time. Whenever they add a vaccine to the schedule, they study that vaccine along with other vaccines. The schedule's been studied for years. It's been studied to be safe. It's been studied to be effective. And that keep in mind that when a baby or a kiddo cries and screams while getting an immunization, that's sort of normal. That's what they're supposed to do, those big, heavy Hollywood type screams and cries. But that's not that's a normal reaction to getting a vaccine.
Mm-hmm.
And that the vaccines are safe.
I like this comment of that's what the immune system was designed to do, right?
Yep.
Yes, your baby. Your baby is very little and very new, but his or her body is ready for it.
Oh, they get exposed. You got to remember they're living in like this really sterile environment. So the minute they're born, they are exposed to millions of things. And they get exposed to millions of things every single day that are brand new. And that's what the immune system's supposed to do. You exercise it. It's like anything else. To make sure it stays healthy and works, you got to exercise it. And by giving those vaccines, we're able to exercise the immune system so that it can recognize it when it contact with it and build up its defenses and protect you.
And delaying vaccines does make your child susceptible to those serious diseases. So,
Yeah.
So we have, and go ahead and keep chat. We're going to keep the line open for 15 minutes. So chat in other questions that you have and other ideas that you have to overcome those commonly asked questions that you get so that we can provide those as resources. This is like the one topic that we really wish that we were in person for this year, because it's really, you do this every day. You are the experts, and our coverage rates indicate that you are good at what you do. Yep. And in partnering with families. So we really want to be able to help you provide ideas to each other. And we have just a couple kind of broad helpful tips. So the first is present vaccination as the default option. Research shows that by doing this and by being confident, parents will and patients will be more likely to choose vaccination. So saying today you are receiving a flu shot, today your child is receiving 3 shots, Tdap, HPV, and meninge. Parents who have true concerns will ask them, they will voice them, but some people who think they're supposed to ask a question will not ask the question and will go ahead and immunize. So when you do get a question from, or sense a bit of concern from a parent, oh, I'm not sure about that flu shot, the first thing you should do is give your strong recommendation. You're trusted, you can share science and anecdotes if you want. They would not be expressing concerns to you if they didn't trust your opinion. So if you say, today you're getting a flu shot, and they say, I'm not sure about that flu shot, I strongly recommend you get this flu shot today. That's the first thing that should come out of your mouth. Because research, again, shows that your strong recommendation goes a long way, especially when you deliver it confidently. And sharing that, you know, I believe in this so strongly that I got my flu shot this season, and I also got my family's flu shot this season. Now, parents still will have questions, patients still will have questions. Please just listen to those concerns, do it in a non-confrontational way, corroborate what they hear. No one wants to hear no. If someone says to you, but I'm scared that this will cause autism, don't say no, it doesn't. Tell them, yeah, a lot of parents are scared about that. Make sure that folks feel heard, and be honest with the information that you provide to them. We have science on our side for this, for vaccines, so go ahead and share that. But when they ask, will it hurt? Say, yes, it might hurt. Don't sugarcoat and say, no, it won't. When they ask, is there a possibility for an adverse reaction, not a typical reaction, say, yes, there is a possibility. It's okay. You need to be able to provide a judgment-free zone, but also build trust with those patients for their overall health, not just related to immunization. And we know that success, it comes in so many different forms. Sometimes you just catch a mom or a giant 6'5" tattooed guy on a bad day, and you know that they're not open to listening. But the next MA or the next nurse gets them on a good day. And we know that what you do with your patients and educating them about vaccines literally saves their life and is the most important thing we think that you do. So, all right, well, it's 1 o'clock. So we are gonna stay on. We have a lot of questions and things in our chat log. So we're gonna stay on for 15 more minutes. And in the chat log, you'll see a link to our Survey Monkey if you can't stay on. And our next session is August 5th. Please fill out the evaluation on August 5th and give us your ideas about what you want to spend time on. And I'm gonna stop sharing our screen, but Chris, could you go ahead and launch that poll that's the next poll, or do I have to share my screen to do that? Let's see. Oh, there it is. So for those of you who are still on the line, we're curious how we should spend our time together on August 5th. It's our last tip session. So we're not sure, do we want to continue what we were thinking of was best practices from sites that have high coverage rates, but knowing that we have kind of tried to cram as much information as we could in each of these sessions. Do we need to cover something in a little bit more detail, or are you interested in something else? So go ahead and answer that poll. And Macrina, I have lots of questions for you in the chat. I do want to make sure that we circle back with a lot of folks listed as adverse reactions, things that are typical reactions. So can you just remind us again what the difference is?
So
after receiving a vaccine, that's something you'd report, correct?
right. So a typical reaction is going to be a sore arm, maybe a little swelling and redness. Usually that's going to go away in 24 to maybe 48 hours. It's usually 48 hours would be a little long, but we start seeing swelling, something that feels like a baseball, redness, warmth. That's going to be a true adverse reaction. A normal reaction is going to be a sore, sometimes slightly swollen arm. A typical reaction is going to be a slight fever. Sometimes kiddos can get a fever even higher than that. You know, maybe up into the 102 range. But if the parent can treat the fever and the fever goes away in a couple of hours with whatever fever reducer they use, cold baths, and that's the typical reaction, not an adverse reaction. The rash following an MMR 7 to 14 days after getting the measles vaccine, very normal. And so that's your typical reaction. Sometimes with varicella vaccine, you'll see somebody get a little varicella vesicle. Usually you see it around the injection site. Again, very normal.
Okay, thanks. So what is another question we got? Big question. Can you give MMRV to a 12-month-old because of more febrile seizures?
No. Recommendation is that first dose of MMR to a child who's between 24 months and 12 months. We always give MMR and varicella separately. As a child gets older, usually 2.5 and older, if they're coming in for their first dose, we will give MMRV if there's no history of seizures.
Okay. And then there's a lot of comments from the video about, it looks like after Kristen provided the shot, she gently massaged with the cotton ball after the shot. Is that what we're supposed to be doing?
A lot of times we'll go ahead and do that, especially we'll hold the cotton ball over after we pull it out. And we'll just massage it just for a few seconds while we kind of chit chat about this is what you're going to expect. Make sure you move your arm a lot. And then we go ahead and put the Band-Aid on.
And Jennifer in our chat says they have patients do 10 big arm circles and then tell them they have to increase physical activity and fluid intake on vaccine days.
Yeah, we sure do. Drink lots of water. We sometimes make the joke of you need to go home and watch the Karate Kid because you need to wax on and wax off. We always make a lot of jokes, especially with our adolescents. Now, Mom, you've got to have some chores for him to do, okay? You know, you can wash the windows, you can sweep the floor, but playing with your thumbs in a video game is not exercising. Unless you're going to play the video game like this. And so usually, you know, it makes light of it. They all laugh. It's a little bit of humor, and they leave smiling, and the mom has somebody to do chores for a couple of hours.
Yeah. So Aubrey's asking a really good question. Should parents alternate Tylenol and ibuprofen for kids or just stick with one another?
Oh, you know, I don't actually know the answer to that. Usually we just tell parents to use whatever they routinely use. We no longer pre-dose with Tylenol though, and that's a new recommendation. Came out several years ago, is
Right.
that they discovered that vaccines don't get a good immune response if you give them Tylenol prior to the vaccine. So we always tell them to wait until the child gets a fever before you dose with Tylenol or ibuprofen, but we never tell them to alternate.
So this might be a good opportunity to show folks. I'm gonna go up. I'm gonna go to the internet. So CDC has this fabulous resource that is available called Ask the Expert. So I'm going to Google CDC Ask the Expert. And then, oh, it's the first thing that popped up here. And then, so this is the main landing page for Ask the Expert. You can look up all sorts of things for that. But we know that most of you, don't have time to do that because when you have a question, you have a patient in an exam room. So what you can do is just go right ahead and click on this email. And so the question was, should we recommend parents alternate ibuprofen and Tylenol after vaccines? Thanks. And I'll say, and we'll see if this question gets answered right after, because oftentimes those Ask the Experts get answered in like 2 minutes. So
Right.
it's a good resource for you all. Okay, so another question, Angie is asking, where do we give, sometimes parents ask for a list of ingredients. Where do we find that?
CHOP, the Children's Hospital of Philadelphia, they have a really good, if you go to that website, they have everything you'd ever want to know about ingredients. And actually you can get, you go there and they will actually give a list of ingredients and which vaccines have them.
Yes. And the great thing about those CHOP resources is it says what the ingredients are for. And, it explains why they're in there.
It does actually tell parents that there's a reason for them. And the reason for them is to keep the vaccine so it's safe and will actually be effective.
Right. And it's more the way that they line, it's a more education, it's a good educational piece for parents and for you. I mean, you get asked these questions, you need to know what they're for. Do we have to sign a refusal form have to have parents sign a refusal form if we document the refusal in the EMR?
I always make them sign something because that shows that we can actually document that they're the ones who refused it. We always document it in the EMR, but it's always nice to have that form somewhere.
And I would check with the owners of your practice if they, there might be a reason why they are or are not having them sign refusal forms. They may have, talked to their liability insurance carrier or something like that. But it is best practice to have them sign that refusal form. And it's also yet another opportunity to educate the families that, and the reason a lot of people use AAP's refusal form. And when you look at it, it's a good educational tool as well.
Well, I also think that sometimes when I go to pull out the refusal form and I'm actually screening with a parent, they're like, well, what do I need to sign this? And I said, well, because you're refusing to follow recommended medical care for your child. And then it kind of drives home the point that, well, maybe this is a bigger deal than just saying, I'm going to wait. I don't want to do this right now. So then it kind of opens that dialogue again. And I do have to say that probably 40% of the time when I have someone sign a refusal form, they'll go ahead and say, I just didn't know it was that big a deal. And
yeah.
Get them.
They also, some people use that as a way to communicate to parents what happened, in the event of a measles outbreak. Here's the things that are going to happen. You're not going to be able to make an appointment. We need to know.
Right.
Call our office or make an appointment because you can't be in the exam room with an infant and other stuff. And we'll share, CDC has a good resource on that too. I find that mixing up the order of adolescent vaccine recommendations is really effective, saying Tdap, HPV, meningococcal rather than Tdap, meningococcal, HPV. So that's a really good tip.
Yep.
Tip shared. What other questions? People are asking for resources, which is great. People are very excited about CHOP. Some of you are already going on the CHOP website. And we have a lot of resources on TAPI's website too, on whyunited.org. What do you do if you give a vaccine IM that was supposed to be sub-Q?
So the first thing you do is, so you give a vaccine that's supposed to be given IM, but you give it sub-Q? Okay, so in that case, the vaccine does need to be repeated, but we also may see a substantial side effect because those vaccines that are meant to be given IM, if they're given in the subcutaneous fatty tissue, are more likely to cause maybe a local infection, a local reaction. Sometimes we'll see an aseptic abscess form. So you really need the parent to watch that. You need the parent to pay close attention, and then you're going to bring the child in. Routinely, when that happens, we recommend you wait the minimal interval between those doses. Oh, and you're definitely going to document it and share it with your provider or your supervisor, whoever that would be.
You are going to tell someone it's okay that you make mistakes.
Right.
Right. We just need to make sure that someone knows about those mistakes so that you can put things in place. And do they put that in VAERS as well?
Yes. Yes.
Okay.
VAERS now wants all vaccines. So if there's a vaccine error, whether it's a vaccination error or a schedule error, they want those reported as well.
And they look at that, right? Haven't they?
Right.
They make changes based on errors that are reported to VAERS, right? And packaging and things like that.
Right. So if you actually go to the Immunization Action Coalition, the site that Rebecca was at a while back, they will actually list all of the most common heard, seen, and reported vaccine errors. And so actually, we find that really helpful in helping us build policy and procedure on our end, because if I figured if somebody else could do it, so could we, right? So, because nobody's perfect. So that kind of helps you kind of proactively think about, ooh, that could happen to us. This is what we should do.
Yeah. And Rhonda's commenting and the question about sub-Q IM, what about polio?
Well, polio is given sub-Q. When it's given, polio can also be given IM. That's probably the one that is probably the only vaccine that is one way or the other.
So polio would still count as a dose probably.
Correct.
And be given
Correct,
each
because we actually, all of your combination vaccines have polio in it. Well,
Right.
yeah.
Yeah, it depends on the vaccine.
Yeah.
Right.
Yes, PPSV, I just saw that note. PPSV 23 can be given IM or sub-Q as well.
Yeah, I think the biggest, we hear so many errors at our tips thing. So when you think about the other, if you're the VFC coordinator, vaccines is kind of your thing and your passion project in the practice, but it's not, the other girl cares about early childhood development and this one really cares about the geriatric population and that's all she wants to see. So you just know that what seems obvious to you might not be to everyone else in your practice. We have heard about people who've mixed their own vaccines in TIPS training. We've heard about people providing vaccines wrong. We've heard about people, super gluing needles onto oral vaccines to administer them that way. I mean, we've heard the gamut. So all of the information that you hear, just think about how you're going to share that in your practice, because no one wants to do errors and they're all trying to do the right thing. So we're counting on you to share all of that information. So, but that is all the time we have for today. We're gonna end this up. Please take the evaluation and tell us what you want to hear about in 2 weeks. So thank you all so much.
Thank you.